Hello and welcome to Sign Out with the Professor. We'll begin very shortly. Well, once again, welcome everyone. I'm going to go ahead with the introductions because we have a guest professor with us today, and his experience and background is sufficiently lengthy and significant. I want you to all be aware of it. So our guest today is Dr. Kyle Wright, who is a graduate of the University of Connecticut Medical School. And following medical school, he migrated slightly northward to Boston, where at the Brigham and Women's Hospital, he was a resident in pathology and subsequently also a fellow in hematopathology, doing a year of research as well as clinical work there, and serving as a post-resident fellow in hematopathology before coming to the University of Oklahoma, where we're very grateful to have him as our director of the hematopathology division in the Department of Pathology. And we really appreciate the expertise and the perspective that he brings to our department, and look forward to the cases that he's going to share with us today. I'll also point out that we have another guest on our call today who's a member of our faculty, Dr. Jeffrey McBride, who's a dermatopathologist, and hopefully will also be willing to be a guest professor at some point down the road in the future. So with that, I'll turn the time over to you, Dr. Wright, to share your screen and lead us through interesting cases.
Absolutely. And thanks for those kind words of introduction, Dr. Hassel. It's very kind of you. And I am very happy to be here at the University of Oklahoma as well. And it's been a great transition process over the past year. And one of the things that we're looking forward to is actually growing out this cutaneous hematolymphoid neoplasm service as we bring more and more DermPath onto our campus personally. So today I wanted to talk about this differential cutaneous hematolymphoid neoplasms from a hematopathologist's perspective. And just by way of getting us, before we get into the cases, really want to just talk briefly about how to handle cutaneous heme neoplasms at your home institution, whether or not you're coming at it from a DermPath or a HemePath perspective. I think the workflow can be challenging to establish and really requires, an understanding of who you have in terms of your personnel in HemePath and in DermPath, really. But it is an expertise that needs to at least have some level of coverage, I think, at your institutions. I think you can do it one of two ways. You can either come in through DermPath and they get the initial look at it and then signed off by HemePath to make sure that it's signed out adequately, or vice versa, where it kind of comes through HemePath and then checked off by DermPath. I think that this is necessary given the ever-increasing complexity of sign-out in surgical pathology, especially in hematopathology, which is about 5 to 10 years ahead in terms of the genetic understanding and of our neoplasms, as well as those being integrated into the diagnostic and prognostication process that we have in heme neoplasms. I think the most critical aspect is that both services get some look at it, because there's certainly going to be some blind spots for HemePath in terms of derm entities and vice versa. So I think it's really important to have a strong collaborative connection, and that's something that Dr. McBride and I have been working on at our institution with the other dermatopathologists and hematophathologists. So we'll start with an easy one, kind of a very common one. Case one is a 66-year-old male. He has a history of erythematous non-pruritic rash evolving over a fairly long period of time, about 10 years. Duration, it's been resistant to topical therapies. And I gave you two punch biopsies to look at, one from the patient's left forearm and one from the patient's left abdomen. And we'll look at those briefly here. So here's a skin punch biopsy. What you can see is we have a superficial dermal perivascular infiltrate. This is a very common look for this entity. If you go and look at those cells at higher power, you can see that most of those cells are composed of small lymphocytes. Some of them have somewhat angulated nuclei like this. Some can get a bit more complex if you look pretty hard at it, but they mostly sit up in the superficial dermis There's a little bit of tagging or interface activity of the dermal epidermal junction. And you might have some egress into, or some what we call lymphocyte exocytosis into the overlying epidermis, and formation of structures like this, clusters of these lymphoid cells. Giving you guys a good look at the H&E. As we move into the immunos, you can see that most of these cells are CD3 positive, so these are T cells. So we're in the T cell domain. This is a CD20. So you can see very, very few B cells, very rare. So that infiltrate is almost entirely composed of T cells, very few B cells. T cells, this is a CD4. You can see that the cells are positive for CD4, including some of those cells that are getting up and into the epidermis here. And there's very rare CD8 cells. So once again, this lymphocytic infiltrate is composed predominantly of CD4 positive T cells. We now have CD2, CD5, and CD7. These are pan T cell markers, which can occasionally be lost during heme neoplasms, especially T cell lymphomas. You can see in terms of CD2, it looks like that expression is relatively retained. CD2 is one of the most robust T cell markers, so it's very often the last one to go. This is CD5. There might be some partial loss of CD5, but it looks like for the most part it's retained. And here's CD7. Probably demonstrating partial loss, a very common finding in this entity, partial loss of CD7. Here we have CD30, and in this slide, you can see that there may be some rare CD30 positive cells, kind of intermediate size cells, but they're few and far between at this site. And this last is CD25. Once again, fairly rare CD25 positive cells here. Okay. From the other body site, you can see something that looks somewhat similar, but also has some different qualities here. It's a bit, the inflammatory infiltrate is still positioned appropriately. So a superficial perivascular and periadnexal infiltrate, similar pattern of morphology and similar pattern of ingress up into the epidermis, so called epidermotropism. And you get formation of these very large structures in the epidermis composed of these neoplastic cells. These are so-called Potriers microabscesses. And you can see, unlike the last case, the cytology of this case is a bit different. You're getting a lot more of these intermediate to larger size cells with more open chromatin, prominent nucleoli, a bit more complex nuclei. Those lesional cells are still all CD3 positive T cells, as you can see here, including a lot of those that are at that epidermal dermal junction, as well as in those Potrier microabscesses. And unlike the last case, when you look at CD30, you see a lot more CD30 positive cells, especially all of this tagging of the epidermal dermal junction. So this is actually a fairly straightforward case of cutaneous T-cell lymphoma or mycosis fungoides. This is far and away the most common cutaneous hematolymphoid neoplasm that we see. It's characterized by this marked epidermotropism of T cells. That's because they express an integrin pattern that allows them, after ingress into the superficial epidermis, to migrate into the, or in the superficial dermis to migrate into the epidermis, and formation of these Potrier microabscesses. You hear in textbooks about this hyperconvoluted or cerebriform nuclei of these cells. This is much more apparent when you're actually seeing these cells circulate and you're getting a cytology look at them rather than embedded in a typical H&E. So I always am impressed when people pop down an H&E and they're like, look at all these cerebriform cells. I'm like, oh, really? I can't see those. So you really don't see that cerebriform nuclei that are characteristic until you get out into the periphery. This is a CD4 positive T cell lymphoma by definition, and CD7 loss is common, but remember that CD7 loss is non-specific finding. It's seen in also reactive T cell proliferation. So you can't hang your hat ever on the loss of CD7. It does have this characteristic clinical progression from patch stage to plaques to tumor stage, and this is usually associated with changes in the overall histology of the cells, increasing cells at first from patch to plaque, and then a large cell transformation, usually with acquisition of CD30 expressing intermediate to large size cells as you move into the tumor stage, the actual fungoidy-like or mycosis-like lesions, the mushroom-like lesions of tumors in mycosis fungoides. This large cell transformation, by definition, is greater than 25% of your cells being CD30 positive large cells. But that's not the only way that they can transform. You can actually get, as I mentioned before, progression to Sézary syndrome, where these cells actually become systemically circulating and can seed in lymph nodes and non-lymph node organs, as well as in the peripheral blood, where you get marked erythroderma, as well as some other changes too. So, but they're all still the same lesion, mycosis fungoides. TCR gene rearrangement we often do as an ancillary test for clonality and to track the clones. So oftentimes the most important part about cutaneous hematolymphoid neoplasms is the clinical correlation and tracking these lesions over time. So being able to establish what the clone is important, because you can track to see on subsequent biopsies whether or not you have a similar or new evolving clone. This is important for just tracking purposes. Sometimes we'll also express for CD25 expression on these cells. This is mostly for therapeutic planning. There is one drug that's variably available in the United States based on your institution called ONTAC, which is basically disrupt CD25 signaling. Remember that from your basic immunology that CD25 is the high affinity receptor alpha chain for IL-2, which is required for T cell clonal expansion. So if you muck up that pathway with this drug, you can actually prevent T cells from clonally expanding, which is why it works in this neoplasm. So oftentimes we'll utilize CD25 just for treatment planning purposes. Okay. Fairly straightforward case. We'll move on to the next case as a point of contrast. This is a 41-year-old female. She's presenting with a 1-year history, so a little bit shorter history of a severely pruritic eruption on her face and neck. Oftentimes this lesion can be even much more acute than this, certainly less than a year. He also has a past medical history, including ovarian and CNS cancers. We'll take a look at the biopsy here. And similar to the last case, you do have a superficial dermal perivascular lymphocytic infiltrate composed of smaller cells. But that's not just lymphocytes. You've got some granulocytes in here. If you look around, you'll see some plasma cells. If you look really, really hard, you might see an eosinophil or two, if you really looked at this slide. And unlike the last case, you can see that the epidermis shows some different changes. So you have some spongiosis here. You have thickening of the epidermis, acanthosis, and you have some focal parakeratosis as well. So somewhat similar to the last case in that you have this inflammatory infiltrate. It's fairly paucicellular. It's not fairly rambunctious like your typical band-like infiltrates that you might see in a lichenoid-like process. So similar to our last case in that regard, except the epidermal changes as well as some additional other cell types, including eosinophils. And this is very much a classic case of eczematous dermatitis or on the spectrum of a hypersensitivity reaction. And oftentimes we're trying to differentiate, and this I'm sure that Dr. McBride would agree here, this is pretty much the differential is early stage CTCL or mycosis fungoides in the patch stage versus some of these other inflammatory dermatoses that you see, of which there are a panoply. This being a very common one. And it can be difficult to distinguish at this early stage. You saw that there is some morphologic overlap, but what you should point out to distinguish these things are a couple fold. One, eczematous dermatitis is usually associated with these characteristic epidermal changes that we pointed out, the spongiosis, acanthosis, plus or minus parakeratosis, which you typically don't see as much of in CTCL, especially at the early stages. And then also, as a point, if you do see eosinophils in here, you should be thinking hypersensitivity reaction. Now, not that eosinophils aren't seen in CTCLs, of course they can. Nothing is absolute in medicine, biology, or certainly pathology. But eosinophils are also associated with systemic T cell lymphomas. But for whatever reason, CTCL or mycosis fungoides typically does not have a lot of eosinophils in the infiltrate. So if you're starting to see eosinophils, yeah, thanks, Dr. McBride. He says he absolutely agrees. If you see eosinophils, pump the brakes, as it were, on straight calling the CTCL. Consider other neoplasms and non-neoplastic dermatoses as well before you jump to CTCL. If in doubt, get a TCR gene rearrangement. Should be positive in your CTCL cases, but for the most part should be negative in most of these cases. There are a few exceptions, including lymphomatoid papulosis, which we'll talk about briefly later if we can get to that case. All right, moving right along. Case number 3. This is a 64-year-old female presenting with an asymptomatic papule on the Vertex scalp. You can see, unlike the first 2 cases, although we do have a superficial dermal infiltrate of lymphocytes, unlike the last cases which had this epidermotropism where the lymphocytes get into the epidermis, you can see here that the epidermis is fairly spared. And you have this clearing out right underneath the area before the infiltrate begins. It's fairly sharply demarcated like this. This is so-called Gren's zone or Gren's layer. And this is classic for lesions of this ilk when they involve the skin. So you can see that this infiltrate, unlike the last one, which was a superficial perivascular periadnexal infiltrate, this one actually has set up some level of underlying architecture. It's composed of both kind of smaller sized lymphocytes and some larger sized lymphocytes, as well as some background macrophages as well. Fairly few, if any, granulocytes. There might be some plasma cells in here. And you can see that this lesion, if anything, grows deep. So it comes in where the vessels are in the superficial dermis, but instead of growing upwards, it grows downwards into the deep dermis. And if there was subcutaneous tissue here, very well could have tracked down into the subcutaneous tissue. Okay, so this is a CD3. You can see that there are some T cells, a decent number of T cells, but there's certainly a lot of cells here that are negative for CD3. So the CD3 is kind of ringing at the periphery of these nodules. Here's CD20. You can see there's a ton of B cells here forming these nodule-like clusters. This is a CD10. You can see that they're strongly CD10 positive. This is a marker for germinal center derivation. They're also positive here for BCL6, another marker for germinal center derivation. This is a CD23. Remember, CD23, CD21, and CD35 all highlight follicular dendritic cells. So you can see here the underlying follicular dendritic cell meshworks, which are associated with this germinal center-like structure that's being formed. This, I believe, is key 67. This is a marker for proliferative index, right? So proliferative cells are positive, and you can see this is fairly low throughout, maybe 5 to 10% in these areas. This is atypical for a germinal center. Remember that normal germinal centers is a proliferative process, so you'd expect the proliferative rate to be fairly high and polarized. Remember that follicles are typically polarized into light zones and dark zones. You see breakdown of that here. And if you look for BCL2, it's very, very much positive in these cells. Remember, BCL2 normally stains T cells, but it's not normally seen in B cells unless it's a B cell lymphoma. B cell lymphomas other than this entity also express BCL2 often, except for Burkitt. So if you see BCL2 positivity in B cells, you should be concerned for a B cell lymphoma. And in this case, given the totality of the evidence, this is a primary cutaneous follicle center lymphoma, or PCFCL. As I mentioned, this has this preserved epidermal features of its Gren's zone and Gren's layer. It may show a follicular or diffuse growth pattern. And unlike this case, which had a BCL2 positivity and actually had a translocation 1418, which juxtaposes the regulatory elements of the immunoglobulin heavy gene upstream of BCL2 to provide an anti-apoptotic signal to these cells, primary cutaneous follicle center lymphomas, like pediatric type follicular lymphomas, are often negative for BCL2. And often negative for the canonical 1418 translocation. Recent studies have described that there are actually other recurrent mutations in these cells, including CREB-BP, KMT2D, the chromatin modifier EZH2, and EP300, as well as 1p36 deletions as another oncogenic mechanism outside of the translocation 1418. And I think an important point to make here is that I always advise imaging in these cases to have the clinician discern whether or not this truly represents primary cutaneous follicle center lymphoma, which has a better prognosis, rather than secondary cutaneous involvement by a systemic follicular lymphoma, which would carry a worse prognosis and higher potential to transform to DLBCL. So I always advocate for them to do some level of imaging to look for lymphadenopathy systemically to see whether or not these are primary or secondary involvement. And as an aside, if you are sending for IGH gene rearrangement testing, which is often required for clonality assessment in these tumors, beware of the concept of pseudoclonality, which is that these lesions sometimes can have a very much a paucity of B cells, especially in small tissue biopsies of the skin. So if you send those and there's actually a relative paucity of B cells, you can actually be fooled because you're just sequencing the relatively few cells that are there. So you can get this problem with pseudoclonality. So just be aware that if you're sending something for gene rearrangement testing, make sure that you have a decent amount of the infiltrate present. All right, case 4. This is an 89-year-old female. She has a history of CLL/SLL, so chronic lymphocytic leukemia / small lymphocytic lymphoma. She's been treated with rituximab, an anti-CD20 monoclonal antibody, and now is presenting with a new enlarging lesion on the left arm. So hopefully you can see a similar pattern start to develop with these lesions. So once again, we have a superficial dermal infiltrate, lymphoid infiltrate, preserved epidermis, preserved Gren zone. So just from the first 3 cases, one being a T-cell lymphoma, one being a B-cell lymphoma, before you've even looked at the immunostains, you should be highly suspicious that this is a B-cell lymphoma. It's come in, it has not gone into the epidermis and has started to grow deep. So I'm thinking B-cell lymphoma before T-cell lymphoma. And you can see, unlike the last cases, now you have pretty much a sheet of these cells. These cells are somewhat intermediate to large in size with open chromatin, variably prominent nucleoli, much larger than our previous cases. And it's pretty much consistent morphology throughout the entirety of the lesion. It's just trucking through collagen, destroying collagen. It doesn't care. It goes down here. This is probably actually where the subcutaneous tissue starts. You can see some fat here, and you can see that it's just cranking right through. Doesn't care. Here's CD3. You can see that there are some T cells, but the vast majority of the T cells are negative, or cells are negative. The cells that are marking as T cells are relatively small in size, unlike our larger neoplastic cells. This is a BSAP or PAX5, or if you're a fan of the gene, and you can see that's diffusely and strongly positive in our infiltrate. So this is a B cell derived tumor. It's a B cell lymphoma. CD5 is negative. It just highlights the T cells again. This is important prognostically for this lesion. This is a CD10. It's showing stromal staining, but relatively little staining of the neoplastic cells. BCL6 looks pretty positive in most of these cells. So that's one marker for germinal center derivation, one marker against germinal center derivation. And here is the MUM1 or IRF4, which is also positive. We have threshold cutoffs of 30% positivity for calling these things positive. So it's BCL6 and MUM1 positive. So a non-germinal center derived lesion. This, I believe, is the BCL2, strong and diffusely positive. CMYC, also strongly positive in a lot of these cells. This is the Ki67 proliferative index, and unlike the last case, you can see it's fairly high throughout the infiltrate, maybe in that 40, 50, maybe even focally up to 60% range. And this is the CD23 to look for those underlying follicular dendritic cell meshworks. And unlike the last case, you can see that this lesion is completely devoid of any architecture underneath, which is actually a requirement for diagnosing this lesion, which is primary cutaneous diffuse large B-cell lymphoma, DLBCL, so-called leg type. Leg type is essentially just a reference to the fact that this is a primary cutaneous DLBCL. This leg type is an antiquated terminology. We used to call it leg type, and I guess still do because the WHO hasn't changed the diagnosis line yet, although that might be changing in WHO5. This leg type, as it describes, this lesion was initially described on the leg, but it can happen anywhere. essentially. One thing that gets brought up a lot of times in this context is whether or not we need to decide between primary and secondary here, whether or not we're dealing with a systemic diffuse large B-cell lymphoma not otherwise specified, or DLBCL NOS, or a primary cutaneous DLBCL leg type. It doesn't matter, actually, for therapeutic management. The vast majority of these patients get R-CHOP in the front line, but it may have some level of impact on prognosis, although genetics are now superseding any of these immunophenotypic features of DLBCL in terms of driving prognosis of these lesions. It's more important to really distinguish between diffuse large B-cell lymphoma and high-grade B-cell lymphomas, so-called high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 gene rearrangements. The reason that's important is this actually opens them up to additional lines of therapy, including dose-adjusted R-EPOCH, where they add etoposide to R-CHOP and then adjust the dose up. That's kind of the most important discretion. Also, high-grade B-cell lymphomas typically do much worse than your DLBCL NOS, so it's important to make that distinction, but not necessarily primary versus secondary. I work these cases up exactly like I do a DLBCL in a lymph node. So I get a T-cell marker, a B-cell marker. I get CD5 because CD5 positivity in DLBCL has been shown to be an independently poor prognostic factor. I look for germinal center derivation or non-germinal center derivation, so-called GCB versus ABC types, based on the Hans algorithm, but there are other algorithms you can use. It's by far the most common, utilizing CD10, BCL6, and MUM1. In this case, it's BCL6 and MUM1 positive, so it's non-germinal center derived. We get BCL2 and MYC to look for double expressor status. This is different than double hit status with the gene rearrangement. This is just talking about expression by immunohistochemical stains, which has also been shown to be independently poor prognostic for DLBCL, independent of the true double hit status. And then a Ki67 and usually an EBER as well to look for EBV positive proliferations. Typically, primary cutaneous DLBCL leg types are non-germinal center derived, as in this case. But as I mentioned before, this is likely going away. So as we move forward, we're going to be doing less of this for DLBCL, trying to discriminate GCB, non-GCB, because it really doesn't have as much of an impact on prognosis in the area of R-CHOP. So we're moving much closer to a genetic classification schema for DLBCLs. And if you read from our Nature Medicine paper from my postdoc group, Shapui et al. Is the first author from Nature Medicine in 2018 that looked at the molecular subclassification of DLBCLs. These actually fall into genetic clusters 1 and 5 with other ABC type tumors, as well as tumors from immune privileged sites like primary testicular lymphoma and primary CNS lymphoma. So that's DLBCL leg type. Case number 5. So as a 58-year-old female, history of MDS, myelodysplastic syndrome, now presenting with 2 months of an involving skin lesions. You can see here the theme of the day, the superficial dermal perivascular infiltrate. This is how almost all of my sign-outs morphologically start, because that's how lesions start in the skin, because that's how they get in. Like T-cell lymphomas, the epidermis is fairly intact without much in the way of changes. You kind of have these lesional cells forming some of these clusters. They're trucking through collagen and diving deep. If we go and look at the cytology of these cells, they're kind of intermediate to large in size, open chromatin, variably prominent nucleoli. Kind of looks like the DLBCL with a little bit less prominent nucleoli. Open chromatin, though, very prominent open chromatin. What do we have here? We have a CD34. The CD34 nicely highlighting vessels, but the infiltrate's negative. Curious. This is an MPO, myeloperoxidase, looking for myeloid differentiation. Also dead negative in the infiltrate. No MPO expression. This, I'm guessing, is lysozyme. Indeed, it is lysozyme positive, strongly and diffusely. That's a marker for monocytic derivation. Monocytes will express lysozyme. And here's a CD123, also negative. So it's a monocytic proliferation. Well, that's weird, right? I thought that these are supposed to be myeloid cells, but indeed, this is leukemia cutis. This is AML involving the skin. So the first thing that I want to teach you guys is you should be highly suspicious when you see cells with a blast-like morphology, so intermediate to large in size, mildly irregular nuclei, open chromatin, variably prominent nucleoli, scant cytoplasm. If there's any history of any myeloid neoplasm, number one, so myelodysplastic syndrome, any of the myeloproliferative neoplasms, PV, ET, PMF, or AML or ALLs, or any history of a solid tumor that's gotten chemotherapy. Remember that oncologists are really good at two things, which is treating people's cancers and giving people other cancers, which is kind of what they do. We see this a lot in hemepath because we deal with therapy-related myeloid neoplasms all the time, which is almost always the common next follow-up lesion outside of angiosarcomas of breast and getting radiation and the like, or old school Hodgkin lymphomas when you got mantle cell radiation, or mantle radiation, but almost always it's a therapy-related myeloid neoplasm. So oftentimes it's ovarian, a distant history of ovarian cancer status post-chemo, and now they have leukemia cutis. As an aside, be aware of this in any organ in this context. So just because we're seeing this in the skin, this can present in the GI tract, soft tissue masses as myeloid sarcoma, okay? So always be thinking about this when you see this morphology in this setting. So typically blasts are CD34 positive. So why are they CD34 negative in this case? Well, AMLs that typically involve soft tissue sites, including the skin, are often AMLs with monocytic differentiation, very common. Gingival hyperplasia, very common. Skin sites, very common. Extramedullary sites, very common. And monocytic diff AMLs often are CD34 negative. So you need monocytic stains to assess for these, including stains like lysozyme. Lysozyme is kind of the best one that we found that's been most specific and kind of best staining qualities overall. One of these AMLs, as an aside, that leads to monocytic differentiation are MPM1 mutated or nucleophosmin mutated AMLs. And there's actually a mutation-specific antibody that recognizes MPM1, which localizes to the cytoplasm when it's mutated. So you can actually get a mutation-specific pattern of MPM1 expression. So it's also nice to utilize as a marker when you don't have CD34. So although this is typically enriched in the setting for AMLs with monocytic differentiation, in practice, this can be any flavor of leukemia. AMLs, monocytic differentiation, myeloid differentiation, myelomonocytic differentiation, minimally differentiated, mixed phenotypes, ALLs, BALs, TALLs, as well as our next lesion from an 80-year-old male with a history of MDS, which transformed to AML. It has a FLT3 internal tandem duplication, or ITD. Currently on azacitidine plus venetoclax, a typical anthracycline, and a BCL2 inhibitor, which is standard of care in a lot of patients that cannot be bridged to transplant in the United States. This patient is probably too old for transplant. So azaven or decven, decitabine and venetoclax, becoming standard of care for these patients in this setting. Now presenting with an evolving itchy rash on his Vertex scalp for the past 5 months. And you can see it's very similar to the last lesion. You have the superficial dermal perivascular infiltrate. I guess you're probably getting tired of me saying that by case number 6, but that's the description. This is diving deep all the way down into the subcutis. The epidermis is still fairly uninvolved, and you have a sheet-like infiltrate of these cells with a fairly blast-like morphology, except they may have a bit more of this pinkish cytoplasm than the blasts of the last case. And also, what else do you see here? Not only do you see a lot of these atypical blast-like cells, but you see all of these red blood cells which have crept into this infiltrate, so-called red blood cell extravasation. This is why these lesions typically present as violaceous nodules. They're purple. Why? Because they bleed into this lesion. And it has to do with vascular damage from the cytokines that are actually produced by this lesion. This is a CD123, a marker for plasmacytoid dendritic cells. It's the IL-3 receptor. You can see it's diffuse and strongly positive throughout the infiltrate. This is CD4, marker typically for T cells, but remember that there are subsets of myeloid cells that can have CD4 expression. Just as a note for all of you IHC aficionados out there, this is high quality IHC, right? Even though you have a strong diffuse pattern of CD4 expression in that background infiltrate, you still see these background, very, very dark cells, these are your infiltrating CD4 T cells. And you can see how the difference in expression you can pick out even there. So we often utilize that for T cell expression versus non-T cell expression. So 123 and CD4 positive. Here's CD56, strong and diffusely positive again. This is TCF4, a transcription factor for plasmacytoid dendritic cells, positive. This should be TCL1 and D. This is a proto-oncogene, in this case, an oncogene. Strong and diffusely positive. Mud brown, it's that look that you get when you have a translocation-induced expression of something. Unlike the last, or like, I guess akin to the last case, here's a CD34, nice internal positive control with the vessels, but the cells are pretty much negative. I believe this is an MPO, also negative, got some precipitate here. And what's this stain? Lysozyme. So like the last case, look at the lysozyme cells, the infiltrate, negative for lysozyme. Okay, so this is actually a fairly characteristic presentation of blastic plasmacytoid dendritic cell neoplasm, or BPDCN, a very rare lesion. Where I trained, we saw about 1/3 of the world's cases of BPDCN because we had one of the only BPDCN clinics, and the lab that discovered BPDCN and the underlying mechanisms of BPDCN, the tumorigenesis, are located there. So we have see a lot of BPDCN. Once again, be highly suspicious when you see cells with blast-like morphology and there's a history of any myeloid neoplasm or history of solid tumor status post-chemotherapy. So exactly the same clinical context as before. Unlike the blasts of traditional AML, these are usually more plasmacytoid. They have moderate amounts of cytoplasm, a blast-like nucleus. They usually present with violaceous plaques, once again on the vertex scalp for some reason, and that's usually due to this red blood cell extravasation throughout the tumor. And it's important to distinguish from leukemia cutis because they do get slightly different treatment regimens. However, they can co-occur. You can get collision tumors of AML and BPDCN. You can get them involving different sites on the same person. You can get them on the same site at the same person. You can get them both co-occurring in the skin and the bone marrow simultaneously. And they can all be derived from the same founder myeloid neoplasm. So just think of BPDCN really as another transformation type event from myeloid neoplasms into an acute leukemia-like lesion. BPDCN, although it's super rare, it's actually very easy to diagnose if you can count to 6. So if you can count to 6, you can diagnose BPDCN because it's positive for 1, 2, 3, 4, 5, 6. CD123, CD4, CD56, 1, 2, 3, 4, 5, 6. There are other useful markers that we utilize, including TCL1, which is fairly specific for BPDCN. Outside, it's only seen in really much one other neoplasm in our hands, or T prolymphocytic leukemia/lymphoma, TPLL. We also use TCF4, maybe sometimes CD303. These are markers for dendritic or plasmacytoid dendritic cell derivation, but they are also seen in normal PDCs. So you can't use it necessarily for diagnosis of BPDCN as a neoplasm, but rather that your neoplasm is of plasmacytoid dendritic cell derivation. Okay, BPDCN. Okay, we got a couple more cases to finish up on. Case number 7 is a 33-year-old male presenting with 1 month of a history of an asymptomatic pink ground papules on his trunk. I gave you 2 H&Es here, but we'll only look at 1. So a very paucicellular, not very impressive biopsy. The infiltrate, once again, superficial perivascular infiltrate. Not much going on in the epidermis. If you look at the infiltrate, you can see that these cells, much more kind of reniform or oblong, long elongate nuclei, no prominent nucleoli, kind of abundant cytoplasm in some of these. And some of these cells actually are fairly dead giveaway if I can find some good granulated ones. These are a bit better. So these kind of oblong shaped, ovoid shaped nuclei, moderate amounts of cytoplasm, and kind of granular. This, I believe, is the c-KIT, or CD117. Those are all positive for CD117 or c-KIT. And here's the mast cell tryptase. And you can see that this is positive, and this nice, very nice granular pattern in these spindled mast cells. So both of these mast cell tryptase as well as CD117 are positive in mast cells, and you can see that this is a mast cell infiltrate. And this ends up being, as you might expect, a diagnosis of cutaneous mastocytosis. Positive for CD117, c-KIT, mast cell tryptase. Now, one caveat is that sometimes mast cells love to degranulate. When they degranulate, they lose their tryptase. So they can lose their tryptase positivity, and you can be fooled that you're dealing with something that's myeloid because it's CD117 positive, mast cell tryptase negative. So I want you to be aware of this other stain called chymase, which actually is not lost upon degranulation. So if there's ever a hint, you can go, but you're not sure, you can go to this third stain, chymase, to evaluate for mast cell derivation. In mastocytosis, just like systemic mastocytosis, you get aberrant CD25 plus or minus aberrant CD2 expression, and these are driven just like cutaneous or systemic mastocytosis by KIT mutations, primarily D816V. It's important to evaluate even if you get a diagnosis of cutaneous mastocytosis, it's actually very important to evaluate for systemic disease by bone marrow biopsy, just to rule out systemic mastocytosis, which is going to require systemic therapy, and then also carries a higher risk for progression or involvement by very rare, more aggressive mast cell-based diseases, including mast cell leukemia and/or mast cell sarcoma. So cutaneous mastocytosis, very limited, usually in the skin, localized. You need to evaluate for the possibility of systemic disease. So case number 8, this is a 70-year-old male presenting with a progressive PET Avid thigh mass. Here we have a deep dermal perivascular infiltrate that's moving into the subcutaneous tissue. The epidermis and superficial dermis are fairly uninvolved, so we'll go look at the action. These cells look fairly small and maybe small to some or intermediate in size, look fairly lymphoid. You get some ringing of the adipocytes in the subcutaneous tissue, but otherwise fairly nondescript, as small lymphoid lesions typically are. So immunostains. Hemopath is not afraid to get immunostains because we really can't distinguish what the cells are until we do them. So this is CD3, so another strongly T-cell infiltrate. This is CD20, I believe. Very rare B cells, if any. Here's CD4. So there's an admixture of CD4 cells. Relative paucity of CD8s, but some CD8s, so an admixture of 4 and 8. Huh. Here's CD56, strong and diffusely positive. Remember, CD56 is positive in a lot of cells, including cytotoxic T cells, NK T cells, and NK cells. This is granzyme B, a marker for cytotoxicity, along with TIA1 and perforin. You can see this, you get this characteristic granular staining. Again, cytotoxic molecules are kept in packaged granules. This is TCR beta F1, so it's highlighting some rare cells, probably those admixed small T cells in the background, but the vast majority of the cells are strongly positive for TCR delta. So this is a gamma delta T cell derived lesion, and the Ki67 is somewhat high, kind of intermediate, 20 to 30%. So this is a nice example of primary cutaneous gamma delta T cell lymphoma. When you hear gamma delta T cell, you should think that it's an aggressive lesion, as both systemic and cutaneous gamma delta T cell lymphomas are fairly aggressive. They have a cytotoxic phenotype, so they're positive for things like granzyme B, TIA1, and perforin. They're going to be negative for the alpha and beta chains of TCR, but positive for the delta or gamma chains. And just as a word of caution, I've had to explain this to multiple people, but oftentimes when we submit for TCR gene rearrangement, you're doing this on the gamma locus. The primers are designed to assess the gamma gene rearrangement, the gamma locus of TCR. It does not mean, if you get a positive clonality test in the setting, it does not mean that it's of TCR gamma delta derivation, because all T cells, regardless of if they're alpha beta T cells or gamma delta T cells, rearrange their gamma locus. So if you're going to have one PCR, you design the PCR for the gene that's rearranged in all of the T cells. Probably smart design by Van Dongen et al. Of their primer sets. So it just means that there's a clone. T cell clone. It doesn't mean that it's alpha, beta, or gamma delta. You have to do the immunos to determine derivation. In terms of important differentials in this differential, it's important to distinguish this from subcutaneous paniculitis-like T-cell lymphoma, or SPTCL, which is much more indolent. And that lesion is derived also from a cytotoxic T-cell population, but instead of it being a gamma delta T-cell, it's actually derived from CD8 positive cytotoxic T lymphocytes. Also, you get usually much more rimming of those adipocytes in SPTCL, unlike this, which is much more sheet-like infiltrate. These patients often have an autoimmune history, and lupus paniculitis is often within the morphologic differential. So don't just brainstem neoplasm. So do your homework, do the workup, and get there. Also, clinical correlation, as always, with the heme derm is very important. All right, quickly, 2 more cases. I think we'll have time. So this case, in case 9, is a 49-year-old presenting with 2-week history of a painful flank nodule, very similar to the last case. Deep dermal and almost completely subcutaneous location of this lesion. The superficial dermis and epidermis pretty much uninvolved. And in this case, we have fairly marked anaplasia of some of these cells. Very large, some are boomerang shaped. Some almost wreath-like. We got some binucleation. Holy smokes, look at this cell. How are you doing today? Aya Sauron for all you Tolkien fans out there. So very anaplastic looking. Lymphoid, can't even tell until we see immunos here. A lot of also inflammatory cells, acute neutrophils in the background. A lot more cytoplasm, a lot pinker than your typical lymphoid lesions, which is also characteristic here. So here we have CD3. Most of the cells are negative, not uncommon in this lesion. Got some T cells in the background. B cells, negative. A couple B cells around this vessel here.
Your slides aren't advancing.
Oh, they're not. Can you see here?
No, we're still looking at the H&E.
We're still looking at the H&E.
I'm seeing the IHE actually, Kyle. So I'm not sure.
Oh,
There's a discrepancy. I am seeing you advance.
are you seeing me move in and out?
Yeah, zooming in and out. I
Zoom
can
in and
see
out?
your IHE.
Okay.
So I'm not sure, Dr. Hassel.
There we go.
If it's
Okay,
stuck.
there we go.
You're good? It might have been your computer not catching up.
Yeah, now you're moving.
So this is CD30, certainly strong and positive in a subset of these cells. Granzyme B, there is some cytotoxicity to these cells. Not as much in the way of TIA1, although there's a little bit here. You have to zoom into high power to see those, but and we have perforin. So all 3 cytotoxic markers, we have some at least subset positivity here. And what's this stain? Oh, ALK, anaplastic lymphoma kinase, dead negative. So we have a neoplasm that's negative for CD3, but it maintains the cytotoxic markers. I'll tell you, I didn't show you these stains, but if we stained it for CD4, it'd be positive. If we stained it for other pan T cell markers 2, 5, and 7, you'd likely see a retention of at least 1 or 2 of those markers. But this is an example of primary cutaneous anaplastic large cell lymphoma. So diffuse and strongly CD30 positive, plus or minus an anaplastic morphology should get you thinking about this case. Unlike systemic ALK positive ALCLs, it's almost always ALK negative. If it's ALK positive, you should consider secondary involvement by a systemic ALK positive ALCL. These lesions often have recurrent DUSP22 or IRF4 gene rearrangements, about a quarter of them. And like systemic ALCL, despite its name, anaplastic and large, it actually carries a favorable prognosis with a greater than 90% overall survival rate at 10 years. So it's the one anaplastic and large lymphoma that actually does well. You should keep in mind specifically for skin that there is a differential around CD30 positive cutaneous lesions that includes, which we've already talked about, large cell transformation of mycosis fungoides for our first case. Type C lymphomatoid papulosis, the way you distinguish this is actually by strict clinical correlation. By definition, lymphomatoid papulosis lesions come and go, they wax and wane, and are usually responsive to steroids, but they can be clonal. So be aware that some they can rarely be clonal, so don't let that fool you. The clinical correlation is really required. and or you can get secondary involvement by other CD30 positive lymphomas like ALCL as previously mentioned, primary mediastinal large B-cell lymphoma, and EBV positive lymphomas. And sometimes it's difficult to distinguish between these three, especially if you're getting kind of the initial biopsy without any past history of lesions. So I get a lot of mileage out of CD30 positive cutaneous T-cell lymphoproliferative disorders as a top line, because it does get them what they need in terms of therapy. So it tells them that they can treat with T-cell based therapies or add on brentuximab for the CD30. All right, very quickly, case 10. I wanted to show you this case because, and I'll be happy to stick around too for some additional questions, Dr. Hassel. So for case 10, the reason I wanted to show you this case is it's a very rare bird. You probably will never see one of these cases in your guys' career, but I wanted to show you because I had this in my records. If you're interested, this case is actually part of the ASH image bank and ASH reference cases on the American Society of Hematology's website. So you're welcome to see that case there where we've published this. But this is a 62-year-old male with no significant past medical history, presenting with innumerable skin-colored papules. Spoiler alert, the patient actually did have a relevant past medical history, but because we know so little about this lesion, we didn't know if they were related, so I didn't want to confuse you. They actually had a subsequent history after these lesions of developing acute myelomonocytic leukemia. All right, let's look. So our final H&E of the day, here we have this kind of infiltrate that's all over the place. It's in the superficial dermis, it's in the deep dermis, dives pretty deep. Not much in the way of epidermal changes. And it's composed of these somewhat discohesive cells, a decent amount of cytoplasm, kidney bean shaped nucleus, not much in the way of nucleoli. Some of them have prominent nuclear membranes, little indentations, these little cleaved nuclei. That should get people thinking about what cell types they could be. Maybe macrophages, something of that derivation, Langerhans cells, so on and so forth. But otherwise, it's fairly nondescript of a lesion. Some of the immunos are actually more impressive for the lesional cells than the H&E even. This is a CD3, so there's an admixture of some T cells in here. It's part of this inflammatory response, but the lesional cells are pretty much negative. CD20, so like CD3, there's some foci of B cells, but the lesional cells by and large are negative. CD4, there's some CD4 positivity, maybe small subset, but by and large, mostly getting the T cells, but maybe subset positive. CD8, we see some CD8 T cells again, but the lesional cells, mostly negative. CD34, negative, highlighting vessels and compressed vessels. This is a CD56, negative. Lysozyme for monocytic diff AMLs, maybe a touch. Huh, that's interesting. We have a little bit of lysozyme. Not strong and diffuse like our monocytic diff case, which were like mud brown lysozyme, but a little bit. Myeloperoxidase, not much there, so probably not myeloid. This is TDT. Want to make sure we're ruling out those lymphoblastic lymphomas or leukemias, dead negative. CD123 for BPDCN, also negative. P67, kind of low to intermediate. And I actually gave you 3 additional stains here on a slide. These stains have become somewhat famous because they've been published and taken away off into an archive because of how rare this lesion is. So I didn't have the digitized versions of this, but you can see these in all their glory on the ASH website if you want to look at them further. But here's S100, diffuse and strongly positive, CD1A positive, prominent dot-like nucleoli, and then Langerhans dead negative. So this immunophenotypic pattern, so all the immunos that I gave you, non-specific, except for those last 3, essentially. And that's kind of the point, is that you really need to do these specific stains, otherwise you'll never get here. And actually you need to be thinking about it, otherwise you'll never get here too. So this is actually an example of an indeterminate dendritic cell tumor, or IDCT. It's ultra rare. There are only a few case reports or in one case series in the entirety of the literature. This is derived from the indeterminate, so quote unquote, indeterminate cell, which is a Langerhans cell precursor. And as such, you have an overlapping immunophenotype with Langerhans cell neoplasms like Langerhans cell histiocytosis, which can also commonly be seen in the skin. The difference between LCH and IDCT is that although you're S100 and CD1A positive, because these are precursors to Langerhans cells, they still lack Langerin expression. And because Langerin expression is required for the formation of the characteristic Birbeck granules of Langerhans cells, these are these EM cell, these on electron microscopy, these tennis racket shaped cytologic organelles in the cytoplasm, you actually are devoid of Birbeck granules in this lesion. So in order to actually definitively diagnose it, not only do you have to have the right morphology, the right immunophenotype, but you actually have to do electron microscopy, which we actually did on this case to prove that these Langerhans cell precursors are devoid of Birbeck granules. And unsurprisingly, given its rarity, with only a couple cases reported in the literature, it's still very poorly understood. In this case that we presented and published with ASH, actually, as I mentioned, this patient showed up 15 years later. So I forget what they got treatment in the front line, but they showed up basically 15 years later with acute leukemia. And I actually did sequence the leukemia and this original tumor, and there are shared mutations, but once again, it's an N of 1. So I don't know if there's any, what correlations there are between the development of acute leukemias and progression to acute leukemias from this underlying dendritic cell neoplasm, but I wouldn't be surprised if there is some level of genetic connection between those two lesions. So with that, thank you so much, guys, for your attention. I know that was a whirlwind, but I wanted to get through all those cases in our short time with each other. And so thanks for your attention, and I'll be happy to start answering your guys' questions.
Thank you so much, Dr. Wright. This has been very informative for me, as I'm sure for our listeners as well. So Supanit has a question. He's a trainee in Cambodia. And one of his questions is here, as he's typed in: I have difficulties differentiating between non-neoplastic and neoplastic lesions in heme path. So in a resource-limited setting, what do you think is the best way to kind of approach that first big step in terms of benign malignant?
Yeah, and I think that, heme path, I think that here's where, so scientists, physician scientists like myself who deal with hematopoietic neoplasms, one way in which we do disservice to people that are trying to diagnose these lesions in resource-limited settings or underserved areas is adding this complexity, right? We spend all of our careers at trying to do all of this characterization to advance patient care and diagnostics and prognostication, but at the same time, we're leaving our colleagues that can't do those things behind. And if we're forcing them to say, hey, you need to do this, 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 and this to call it a lymphoma, then we have not done a service to you and your patients in the end. So it's a great question. What in resource-limited settings can we do that can get us thinking about lymphoma versus non-lymphoma? I'll start with the basics. Clinical pathologic correlation, always, 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 right? So do we have any type of imaging? Are there palpable masses in multiple locations? Do they have evidence of adenopathy? If we have CBC data, do they have cytopenias associated with these lesions? Look for autoimmune histories. Lymphomas almost always have some level of immune dysregulation in the background, be it immune deficiency, functional, acquired, or congenital, or immune dysregulation in the setting of autoimmunity. This is how these lesions grow out. So always be looking for autoimmunity in the background. Now, with that being said, you can also get reactive proliferations in the setting of autoimmunity, so you have to be careful of that too. I think morphologically, it's very, very difficult to distinguish a neoplastic lymphocyte from a non-neoplastic lymphocyte, especially when you're dealing with small lymphocytes. Right, a small lymphocyte's a small lymphocyte's a small lymphocyte until we actually bin it, usually by immunophenotyping. So getting away from immunophenotyping is very, very hard in lymphomas, just from a conceptual standpoint. Morphologically, what I'm looking at, I'm looking at things that are a bit more beyond, a little bit more higher level or top down views rather than looking at the individual lymphocytes themselves, which I think is a thing that surgical pathologists and cytologists try to go. They'll look at the cell, look, it's atypical. No, I've seen many reactive T cells which can look pretty atypical, so don't go there. The more important things are, is it a facing architecture, normal tissue architecture? For example, if you're in a GI tract somewhere, gut, colon, etc., are you getting lymphoepithelial lesions? Are these lymphocytes clearly trying to efface sites of normal tissue architecture? Also, in lymph nodes per se, when you're actually dealing with lymphomas, which mostly arise out of lymph nodes, obviously, you look for alterations of the underlying lymph node architecture. So effacement of the lymphoid architecture, obliteration of the sinuses, capsular thinning of the subcapsular sinus because you've got this proliferative expansile mass, okay? Follicular dendritic cell meshwork loss or alterations, especially in high-grade neoplasm. So large cell lymphomas, DLBCLs, by definition have to efface that underlying architecture. So looking for FDCs via CD21 or CD23 as a basic immuno is also good. So I think those are things that you can do in a resource limited setting. Obviously, whatever immunophenotyping you can do by flow cytometry or by immunos is useful. And oftentimes if you have that, that's usually enough. And B cell neoplasms, obviously you can get clonality through flow cytometry, looking at kappa or lambda light chain restriction. More difficult to do in T cells by flow, although there are very new markers that will allow us to do similar kappa lambda monotypia like you do in B cell proliferations in T cells. That's coming, which is great, and shouldn't be too hard to implement as long as you have flow cytometry available. And then I think the highest level then would be if you have a centralized lab, a reference lab that you can send things to for gene rearrangement testing is kind of the ultimate too, because that can just be done on FFPE tissue. But once again, that's kind of the more difficult things to do. And then genetic characterization would obviously be the most robust thing to do, and that would require the most number of resources. So that's kind of my spectrum of low resource to high resource in terms of how I handle lymphomas.
So Dr. Mary also in Phnom Penh notes that they have relatively few dermatologists there doing biopsies, and she's relatively inexperienced. And I think this is an important thing to recognize that pathology is really a team sport.
Yes,
and that we need to be very willing to share cases and ask for opinions from other people, because I've never met anyone who was reluctant to give their opinion or share what they do.
You don't say, Dr. Hassel.
So her question is, if we get something from a dermatologist, how big is the punch biopsy, or how many pieces should they be going after?
Yeah, that's a great
what sort of the lesion should they biopsy? That's very helpful if we can guide them.
Yeah, that's a great question. So I think the most important thing is not necessarily how much or how big. These are typically kind of the punch biopsies that you can do for dermatologists are standardized based on the caliber of the punch biopsy needle.
Yeah, usually 4 to 6 millimeters.
Exactly, 4 to 6 millimeters, and they kind of vary through there, but that's basically it. You're pretty much capped at that. I think the most important thing is to, when you're dealing with hematolymphoid neoplasms in the skin, is to advise to get a punch biopsy, a skin punch biopsy, which is done with these, little punch biopsy needles. The reason being is if they do a shave biopsy, which is another way that dermatologists often do cutaneous skin biopsies, especially from melanocytic lesions and the like, just to kind of shave it off. As you've seen today here, there are a lot of these lesions which are deep. And if you do just a superficial shave, you are likely to miss important diagnostic information deep. So if there's one important thing to guide your dermatologist in terms of getting adequate material, it's to get a punch biopsy so you can see into the deep dermis and hopefully, potentially, if the lesion's sufficiently large, into that superficial layers of the subcutaneous fat too, just to make sure we're getting getting a full-fledged view of what we need to see. That's the more important thing rather than the size of the lesion. Remember also, I can't believe I've had to say this recently to some people, but remember that hematolymphoid neoplasms have no margins, right? Unlike surgical pathology. The margin for heme neoplasms is the air that we breathe. So unless you're coughing up lymphoma cells, you have no positive margin. So if they're asking you for margin status or whether or not these are moving to the lateral edges or deep edges of the margin, which dermatologists love to ask for, tell them, just gently remind them that this is a lymphoma, so it's irrelevant in this setting, because just in case, even if it didn't go to the margin, you can have it right in the vessel next to on the next field over. So these are circulating cells. There are no margins. So just remind them that gently.
Wonderful point. Wonderful point. Well, thank you so much, Dr. Wright, for this very fascinating survey through the hematolymphoid landscape of the skin. I think there's a lot more comes up, and I'm sure as questions come up and people encounter cases, they can feel free to consult you, or if they can't reach you directly, they can send things through me, because as we're trying to help them build their network for contacts and consultations as well. You muted.
Sorry, I was muted. So absolutely, and I've had experience doing this. You know, at the Brigham, we had a significant involvement with Partners in Health, which is, you know, a lot
of outreach there. Yeah.
A lot of outreach there to similar situations. So I'm always happy to consult internationally from any difficult cases that you guys get. You know, even if we can't get fully to a diagnosis on what limited resources we have, being able to do that will help. So any way that I can help you by looking what material you guys do have, feel free, if you to contact me directly, or through, as Dr. Hassel mentioned, through him as well. Okay.
Dr. Wright, I just want to say that was a beautiful presentation. You covered
Dr.
a lot of ground.
Thank you so much.
And you know, what you said about the biopsy technique was absolutely true as well. One thing I would advise people to do if they're suspecting a more deep indurated paniculitis is to do a punch within a punch. It's actually pretty easy to do. So you can do like a punch biopsy like normal, and then you can go right back inside of that punch biopsy spot and get deeper fat as well and submit all of that.
So you're doing like contiguous cores almost.
Absolutely. So it really does help with the paniculitis like T-cell lymphomas and some of those deeper processes that you showed today. But great talk.
Thanks, Dr. McBride. Glad you could be here, and from the derm perspective.
Okay, well, thanks everyone for joining us, and we will look forward to posting the video on this so you can review it at your leisure. The links to the slides that have been used will still be available and viable throughout, and we will look forward to another great session next month in November, and follow up as need be in between. So again, thanks, Dr. Wright, very much for a wonderful presentation, and everyone for participating.
Thanks for having me. Hope you guys were able to learn something. Take care, guys.
All right.